Hello. Today we will discuss evidence-based management of heart failure with preserved ejection fraction. I will share 2023 American College of Cardiology SSC expert consensus in this video. If you are new to this video, welcome. My name is Dr. Farzana Hoque. I'm an associate professor of medicine. So let's jump into it. This video will share multiple important key points which is taken from the most recent expert update on heart failure with preserved ejection fraction. The goal of this video is to highlight the evidence-based management of HFpEF so that you can utilize these key points for your patient care along with your USMLE exams and maybe for board exam. So the first key point, as you may already know, that the heart failure with preserved ejection fraction is defined as sign and symptoms of heart failure with left ventricular EF more than or equal to 50%. Very important point, I believe, from this update is that natriuretic peptides are lower in obese individuals with heart failure with preserved ejection fraction. So we must have to have high suspicion to diagnose heart failure with preserved ejection fraction for patients who have dyspnea and obesity because natriuretic peptide could be lower in obese patients. So how to manage this heart failure with preserved ejection fraction? First and foremost, we have to manage the comorbidities first. We have to optimize the management of comorbidity, which could be heart failure, hypertension, obesity, diabetes, atrial fibrillation, or sleep apnea. So depending on patient's comorbidity, in order to treat the HFpEF, we must have to treat all these comorbidities first. Very important to remember that for this patient, the systolic blood pressure target will be less than 130 millimeter per mercury. And you can use diuretics, ARNI, ARB to optimize their blood pressure control. I found this very much eye-opening from this update that women with heart failure with preserved ejection fraction may have more dyspnea with horse health status. And another important point to remember that our women patients who have heart failure with preserved ejection fraction, they may have more concentric remodeling on echo with more diastolic stiffness, a smaller LV size, and higher EF compared to men. So let's now focus on the target A1C for these patients because we have already discussed that optimizing the management of diabetes or other comorbidity is important. So one of the question is always asked, then what is the target A1C? So this update clearly mentioned that target A1C is less than 7 or between 7 to 7.5 will be for individuals who have less severe heart failure or lower comorbidity burden. In contrast, the patients who have more severe heart failure or higher comorbidity or who are elderly, their target hemoglobin A1C should be less than 8 to 8.5. I should say around target will be 8. So let's recap. Very important to remember for any exams as well as for our patient care that which medications are contraindicated in heart failure. Number one is Dipeptidyl peptidase, DDP4 inhibitors like saxagliptin, alogliptin, along with thiazolidinedione. For thiazolidinedione, the contraindication come because it can exacerbate the volume overload. So we must have to avoid these two class of medications for our heart failure patients. For heart failure, regardless either it is reduced or preserved ejection fraction, it is very important to treat the sleep apnea if it is present. So if you have patient who has heart failure with preserved ejection fraction, obesity, you are suspecting sleep apnea, make sure they are getting polysomnography or sleep study to detect the sleep apnea so that the treatment for sleep apnea like CPAP can be done. And weight loss. Obesity is one of the common comorbidity of any heart failure patient. So, and we know that losing weight is not easy. So for weight loss, need to make sure that we have multidisciplinary approach. Again, to emphasize that long-acting nitrates are not routinely recommended for heart failure with preserved ejection fraction. And you can remember these key points because sometimes I saw that it could be included in any USMLE or board exam. So to remember that for our heart failure with preserved ejection fraction, long-acting nitrates are not routinely recommended. Let's remember that SGL2 inhibitor should be initiated in all heart failure with preserved ejection fractions who do not have any contraindications. And definitely once they are stabilized from the acute heart failure, if they have, but it is preferability to do during hospitalization. So the key point to remember that SGL2 inhibitor should be initiated in all heart failure with preserved ejection fraction patients. For example, like Jardian. I hope you find this video helpful. My goal was to include the evidence-based management, the current update of heart failure with preserved ejection fraction. If you want me to make video on other guidelines or management of other disease, please share it in the comment section. I will make sure to keep your request and make the video according to that. Please subscribe to this channel and like this video, share with your friends and colleagues whom you believe will be benefited from the lessons and wisdom of this video. Thank you so much once again for joining, and I will see you in the next video. Until then, take care.